Hey, good evening, everybody. Welcome to the ASGBI free paper session on education, teamwork, simulation, and training. Welcome to all our presenters. We've got free papers and talking posters tonight. I'm Ian Anderson, the president of the association. My co-chair is Krishna Singh, who'll say hi to you so you can see his face just now. He'll pop up on your screen. Krishna.
Hi, everybody.
Hi, and we're going to co-chair and alternate this. The free papers will go first. You can pose questions to the chairs via the Q&A tabs, and I can see some messages are also coming in on chat, but I can't guarantee to follow those as well and not necessarily to read them out. So I hope you have a good time. It'll be an entertaining session. The abstracts look great, and we'll crack right on. So 3 minutes for the free papers, 2 minutes for questions. The big lever will be waiting for anybody that overruns too far. And first up, I'd like to welcome Ossian James from Wales, going to talk about biosensors, biomarkers, and biometrics, bootcamp perspective. Ossian.
Thank you very much. Yeah, good evening, everyone. My name is Ossian James. I'm a general surgery registrar in Wales and also a Royal College of Surgeons research fellow. I'm presenting a study we conducted called Biosensors, Biomarkers and Biometrics, a Bootcamp Perspective. I'd like to take this opportunity to thank all of our collaborators as well, please. Next slide, please. So stress and burnout are reported to be increasingly prevalent within surgery, particularly within the trainee cohort. Repeated, consistent exposure to stress not only results in this burnout, but several other alarming issues, including increased cardiovascular morbidity and poor professional performance. Stress can be measured in a variety of ways related to time and technology, including structured questionnaires, heart rate variability, thermal activity, and blood, salivary, and hair biomarkers. This is the first study aiming to compare the physiological stress response of a cohort of UK core surgical trainees during simulated training with a holistic exploration of associated or augmenting factors. So 20 trainees were fitted with Vital Scout wellness monitors for a 3-day bootcamp. These monitors captured heart rate, respiratory rate, and used heart rate variability to calculate stress scores. Trainee demographics, event diaries, burnout scores, and learning styles were also collected prospectively. We've actually focused on day 2 of the course, which included interactive lectures in the morning, then clinical skill simulation and non-technical training in the afternoon. Next slide, please. The findings demonstrated considerable variation in the resting heart rate, which didn't correlate with the respiratory rate. However, resting rate was proportionally related to the amount of exercise trainees undertook weekly. Heart rate, respiratory rate, and stress score increased incrementally and significantly in response to lectures, non-technical training, and clinical skill simulation. Pattern day is quite evident with the clinical skill stimulation session eliciting the highest sympathetic drive, which manifests itself as increased heart rate and respiratory rate, and a decreased heart rate variability, which leads to an increased stress score. Next slide, please. Emotional exhaustion, which is a feature of burnout, was associated with high heart rate and stress scores during the clinical skill simulation. Additionally, higher heart rates during the non-technical training was associated with being male. Interestingly, maximal physiological responses were unrelated to what the trainees perceived to be their peak stressor, with a Likert scale of how stressful the day had been for the trainees unrelated to any physiological variable. The findings begin to demonstrate the physiological effects trainees experience and how pre-existing burnout may augment these phenomena, and also the presence of cognitive dissonance between the mind and body. Future work needs to focus on the clinical environment in order for us to develop effective countermeasures. Thank you very much.
Hey, thank you very much, Ossian. Good presentation. Interesting topic, isn't it? Looking at heart rate. Where do you think, or what do you think this tells us about either how we teach or how we train?
I think, much like anything else, we need to train in a realistic environment, really. And as we know, simulation is getting better and better. Gone are the days where we're using, well, plastic models and things, or we still are using them, but there's virtual simulations and new simulating machines coming along now. So I think that would be very, very useful, and might reduce these sort of being stressed in the clinical environment. But obviously that's a necessary evil for us to develop as trainees.
And a question from Christian Makukovic. Interesting topic, enjoyed it. Do you think simulation and training should be incorporated with these stress measures?
Yeah, absolutely. So we've had some experience in our research group of using simulation and doing research with that. We had some lapsing machines brought in from surgical science in Sweden, and that gives you a whole load of parameters sort of surgically. What we'd like to do is move forward and wear these stress monitors whilst doing the simulation, so we can obviously align then the performance metrics with the stress metrics, and use it as a bit of a longitudinal study then to see how people get on with time.
Okay, thank you. We're out of time, and just while I hand over to Krishna Singh for the second one, just leave you the thought maybe we should wear those when we're operating for real, or whether that would be an unhelpful audit tool. I'll leave you to ponder that on the way home. Krishna.
Okay, so thank you. The next paper is Quest for Operating Room Efficiency, from Reporting to Managing. Elizabeth Faulkner, please.
Good evening, everyone. So thank you for the introduction. I will be presenting our paper, Quest for Operating Room Efficiency from Reporting to Managing. Next slide, please. So operating theatres cost an estimated £1,200 per hour to run, accounting for 40% of all hospital resource costs. Yet theatres are not optimally utilised. NHS benchmarking data shows that mean theatre utilisation is 83% for general surgery, 74% for cardiothoracic, and 78% for vascular. We know that delays occur and that they impact patient care. Moreover, with millions of elective procedures having been cancelled due to the recent COVID-19 pandemic, a greater backlog has been created. While we begin to ask how we can make up this deficit, improving efficiency is as relevant as ever. Next slide, please. The aim of our project, run pre-COVID, was to identify the key cause of delay, specifically to cardiac and vascular theatres, and, using existing resources, target these to improve efficiency. We collected 120 days of electronic record data, which served as our baseline. Results are shown here for vascular theatres on the left. We found vascular theatre utilisation was 83%, yet 98% of first cases were reported as starting late, while half of lists had at least one case cancelled. Turnaround time between cases was an average 81 minutes against a UK average of 15. Our initial impression was that there was clear room for improvement. The next step was to try and identify the drivers of these figures. We mapped processes, quality checked the electronic record data reporting, and conducted structured questionnaires and interviews. Process mapping unearthed a mismatch between electronic reporting definitions and clinical practice. The vascular list was reported as delayed if the anaesthetic start was after 8:10 a.m, yet the preoperative briefing was scheduled daily at 8 a.m. Thus, the percentage of high-late starts did not give a true picture of neither the team's performance nor their perception of it. Similarly, the turnaround time was impacted by a disproportionately high number of infected patients at the hospital who necessitated a more thorough clean of the theatre after their surgery. That said, there still exist preventable causes of delay. We found there weren't just systemic issues like porter bottlenecks, but speciality specific, such as last-minute changes to the vascular list due to its high proportion of urgent cases. Taking all this into account, we narrowed our aim to vascular theatres only, implementing an email system that pre-warned of any last-minute changes to the list. Next slide, please. For the 2-month period in which we trialled the email system, theatre utilisation was up 4%, first case delayed starts down 14%, cancellations fell by almost a half, and turnaround time was improved by 23%. We thus exceeded the Trust's target theatre utilisation of 85% and concluded our intervention a success. We did encounter teething issues during the email's implementation, as well as a variance in surgeon uptake, highlighting the importance of stakeholder buy-in. That said, the email system has been embedded in daily practice, showing that if a solution is tailored, effective and affordable improvements can be made. Thank you.
Thank you. I'd just like to ask, we get experts, expensive experts usually employed by the trust to look at where are the delays, where are the bottlenecks in our system. Do you think it's better what you have done from the shop floor to figure out what can be improved on and will be more effective in bringing about change than having external agencies coming in, shall we say, to tell us what's a better way to do it?
Well, I was certainly cheaper. I mean, I think what's shocking is that actually, because everyone is so consumed in their own job, there are few people who have the role to step back and actually look at the system. The fact that 98% of surgery was reported as starting late, but the reality on the ground completely didn't reflect that. And it took sitting down with the lead scrub nurse in charge to go by her day by day, to even work out that there was a complete discrepancy between what a reporting system would tell you and the reality of it on the ground. So, you know, there are plenty of things and money that could be spent to improve theatre efficiency, but actually there is a lot that can be done within the teams themselves if people take the time to look for how things are run and how things are being structured.
Okay, thank you very much. I don't see any questions.
Just one question from the floor, Christian, that I've got, asking Elizabeth, nice presentation by the way, what's the single thing that other people should do to make their theatres start on time? If you had to say one thing.
I think it probably starts with awareness, because I think it probably wasn't just the email system which improved the figures. It was the fact that we were starting a discussion around what constitutes what we would consider good behaviour or not. So I think just actually having that discussion a bit more, because people are busy and that, you know, it can slip your mind, I think.
Okay, thank you. All right, on to number 3 now. Rebecca Fisher, who's from London, King's, Guy's, St Thomas's, development and use of Proximy, an augmented reality telementoring platform.
Hi, I'm Becky. I'm an F3 Research Fellow at King's College London. I'm going to talk about the initial development and use of Proximy. Proximy has been in development since 2016 and is a cloud-based virtual collaboration platform that doesn't need any specific hardware and works on existing hospital Wi-Fi. It's essentially the operating theatre's answer to Zoom, as it allows a surgeon to stream their operation and viewers can interact by talking and using augmented reality tools. Next slide, please. Here's an example of Proximy being used for training in the operating theatre for a robotic urology case. On the left, we can see our robotic fellow who has plugged his console into a laptop and he's wearing a microphone. On the right, we can see his professor in the office, keeping an eye on the case via Google Chrome. They can chat about the case and the professor can draw on the screen if there's anything in particular he wants to point out. An interesting feature is the virtual hand, which you can see on his screen. The webcam on his desk is filming his hand. You can see his hand outreach there, which is then overlaid on the video feed to allow him to point to key structures. Next slide, please. This can be used in lots of ways, and Proximy call it the 3 Ps, so I'll go through that. In step 1, the fellow can prepare by watching past cases. In step 2, a surgeon can perform the procedure with telementoring, as we just saw. In step 3, the surgeon can perfect their skills by reviewing cases with a mentor or at a conference. All of the videos are then stored in a private online library, which can be shared with trainees and colleagues. Other examples of uses include ED staff using it for virtual tertiary referrals, and for device companies to use it for demonstrations without flying their surgeons around the world. Next slide, please. Proximy is currently being used for more than 300 procedures per month, and by 20% of NHS trusts. A wide range of pilot studies have been completed with no safety concerns, and we are now beginning to evaluate its use in routine clinical practice. It poses an interesting challenge for academic studies. In surgical training, it's usually used to help surgeons through the final stages of a learning curve, from competence to expert performance. This is, of course, different to much of the devices and simulation literature, which usually focuses on the early stages of the learning curve. In conclusion, Proximi is a safe and scalable platform that doesn't need specific hardware and is able to work on existing Wi-Fi. This gives it great potential to improve education, particularly given ongoing COVID travel and teaching restrictions. A future challenge will be to accurately evaluate the clinical use of Proximi in real time as the rapid expansion continues.
Great, thank you, Becky. So this is really ideal for somebody doing an operation robotically or laparoscopically, and someone remotely can stick their digital hand in and say, no, 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 cut here, please.
Exactly, yeah.
What about open surgery?
Interesting.
Can you use an overlight camera or something, or not really?
Yeah, so it has been used. The International Society for Hip Arthroscopy have taken it on in quite a big way, and when their consultants do open cases, particularly in the US, they use webcams in theatre. Some of them have them mounted on their lights. As we all know, those images are not always the best. So we kind of recommend having a couple of webcams in theatre. That's kind of been the best thing shown.
Okay. Did you say that you'd concerns about how this would impact on learning curves and research? But surely most trials should be done by people who are already sufficiently up the curve.
Yeah, exactly. So as you, like in that example, most of the people, you only really want to be mentored by somebody not in the room, of course, if you're already safe to do the operation. So this is really for people who are perfecting a new thing. Maybe they've just finished a fellowship and they've gone back home or something like that. Or it's a slightly, they're worried it's going to be challenging and they want to get some advice from somewhere in a different centre. The issue is that a lot of the education literature, simulation studies, we tend to look at novice versus expert. We pick up the beginning of suturing using a certain simulator or something like that, but it doesn't usually capture the very end. And what I think the direction that we're going in with these things, that innovative things that are kind of jumping straight into clinical practice, is we're hoping that we'll start being able to have better mechanisms for just evaluating it in real time. So instead of bringing it back to the skills lab and saying, okay, you're doing a cadaver dissection and measuring quite basic things, then actually beginning to evaluate, okay, well, this society already using it, let's measure that.
Okay. Thank you very much. Fascinating talk. Over to you, Krishna.
Thank you. So the next talk is egalitarianism in core surgical training. Let equity prevail. And this is David Robinson from Wales to tell us all about it. Thank you.
Thank you. Good evening. My name is David Robinson and I'm presenting our study Egalitarianism in Core Surgical Training, Let Equity Prevail. Next slide, please. Differential attainment is defined by the General Medical Council as systematic differences in outcomes when classifying cohorts by protected or socioeconomic characteristics. And the biggest disparities are related to ethnicity. As such, our study aimed to quantify the differential attainment amongst three cohorts. The first being white UK graduates, the second Black and minority ethnic UK graduates, and the third international medical graduates. We examined 264 consecutive core surgical trainees enrolled in the core surgical training programme in Wales between 2010 and 2017. Our outcome measures were ARCP outcomes, IMRCS success, and National Training Number Selection success. Next slide, please. The box in the top left-hand corner shows the outcomes of the univariable analysis against the three cohorts. And although statistically there's no significant differences among the three cohorts with regards to the ARCP outcomes, if we look closer at the percentages, the white UK graduates and black and minority ethnic UK graduates perform on a par across the board. But our international medical graduates, their universal outcome ones were 10% lower than the other two cohorts, outcome twos were 20% higher, and the outcome threes were 10% higher. The picture gets a little worse when we look at NTN success and IMRCS pass rates, with NTN success 6-fold less likely in international medical graduates compared to the other two cohorts, and MRCS pass 20% less. Multivariable analysis identified that UK graduates were 7 times more likely to be successful at NTN selection. We also wanted to use this study to explore a possible intervention. And we're very lucky in Wales to have a professional support unit that functions very highly. They offer support across a variety of issues, whether they be professional or personal. And retrospectively looking at our cohort, over 25% had received targeted support from the PSU. And PSU countermeasures were associated with almost a 55% subsequent success rate in individuals who had undergone exam difficulties, with almost 30% of those having adverse ARCPs or progression issues subsequently being awarded CST, CCT following engagement with the professional support unit. Engagement was varied across the 3 cohorts, and proportionally, our international medical graduates in Wales engaged more with this service, including the 2 international medical graduates who successfully were appointed at national training selection, had both undergone PSU input during the 2 years of core training. Next slide, please. So in conclusion, we found that we had equitable outcomes related to ethnicity among our UK graduates, but there was important variation among our international medical graduates, with them being 2-fold more likely to receive an ARCP outcome 2 or 3, a 5th less likely to pass the MRCS exam, and 6-fold less likely to be successful at national training number selection compared to our UK graduates. So clearly, targeted countermeasures are required to let equity prevail. And we've found that our PSU engagement has shown a potential intervention that we could use. Thank you.
Okay. Well, thank you very much for this very interesting paper. I'm just going to ask you, what inspired you? What was the catalyst to get to start this paper? Did you have a feeling that there was something, there were differences?
So the GMC, I believe, contacted the majority of deaneries, including ours, to sort of point that across all postgraduate medical services, there was an issue identified by them in the annual reviews. Now, that was passed through and basically highlighted to us that we have an issue according to those. So rather than just say, okay, we have an issue and sort of come up with a plan, we felt it was important to identify to what extent do we have an issue and who are the target groups that we have an issue with. And to be honest with you, based on what we were told from the General Medical Council, we thought there was going to be huge disparities, mainly between our Caucasian UK graduate trainees and our black and minority ethnic trainees across the board, whether they were UK graduate or not. And it was obviously pleasing to see that amongst UK graduates, outcomes were equivalent regardless of ethnicity. But it was surprising to see such large disparities amongst our international medical graduates. So that was sort of the driver and what we found.
Okay, thank you.
There's some great questions coming in, Krishna, and some great comments on this. How many other deaneries have a PSU, and how else can we engage with the IMG group rather than maybe sometimes seeing them as a problem rather than as a opportunity and solution, somebody to help?
So with regards to how many other PSUs there are, the honest answer is I'm not entirely sure what other deaneries offer on that front. We worked very closely with the lady who coordinates all of our PSU in Wales with this, and that sort of working together was how we managed to retrospectively look at it. With regards to the sort of identifying the international medical graduates, it's rather than sort of identifying them as a problem group, it was more identifying them as somebody who we could offer further help to. It was more, rather than sort of point the finger, more how can we help to get equity across the board in terms of our outcomes. Now, our PSU doesn't offer a service where it's sort of point the finger, you have to come to us, but it opens the door to opportunities to help, and including sort of counselling and exam support. And the way that we thought that we would run this going forward is sort of advertise greater when these, when all individuals come into core training, the services that we have on offer, and make sure that access to that is as easy as possible.
Good, that's great, fantastic thing you've got there, and thanks for sharing it with us.
Thank you.
Let's move on. Time always presses. Number 6, improving patient experience on the consenting process for surgery by Soo-Yoon Lee and Ian Pearce from Manchester.
This is not my slide.
No, so Ian, this is
sorry if I missed
the
one.
paper before that.
Oh, I'm sorry. I'm a step ahead of myself. Apologies, Dr. Lee and Dr. Kang. Going back to Yuan Chu Kang, objective differences in technical performance during lap chole between set trainees in Australia and surgeons using video benchmarking. Kang.
Well, firstly, thank you for having me. My name is Stu. I'm a general surgeon working in Melbourne, Victoria. If I sound a bit delirious, it's because it's about 4 a.m. here in Australia at the moment. So I'll be talking about our project using video benchmarking to measure technical performance for our trainees and our surgeons. Next slide, please. So I guess to describe the purpose of the project is that surgical training now is more and more moving towards competency training. Our orthopedic colleagues here in Australia has already done that, and our general surgical training program is going to move towards that in the next 5 years. So in a way, we need a way of measuring surgical competency beyond just an expert opinion from our surgeons and surgical supervisors. And so what we try to do is to explore some objective and measurable indicators, which then can be used to differentiate novice and experienced operator, which some of our other presenters has talked about before. Next slide, please. So this is a start of a larger project where we collected a large collection of videos of lap choles performed by a number of trainees in their 3rd to 5th year of the training, and fellows and surgeons. So the videos are then edited in a standardized fashion and blinded to a hepatobiliary surgeon who reviewed those. We had a set of predetermined benchmarks, which is aimed to measure technical efficiency, tissue handling, surgical safety, etc. And at the end of the review, the hepatobiliary surgeon will also rate the performance of the overall procedure on a scale of from totally unsafe to developing skills, competent, and expert. Next slide, please. So these are some of the differences that we found. So the number of instrument changes that is taken by a trainee seems to be higher than an experienced surgeon. A gallbladder rotation is described when the gallbladder is flipped from the left to the right side, just basically working on the medial side or the lateral side. The number of time that Hassman's pouch needs to be regrafted during the operation, and obviously the dissection time. So given that it's a blinded study, is always worried that if the surgeons don't perform as well as trainees, so this is quite a reassuring thing that there is a difference. Next slide, please. And when we look at the subjective rating that was given by the hepatobiliary surgeon at the end of the review of the video, we do find that the surgeon and fellow performing the procedure do get a higher rating overall as compared to the trainee, which is quite reassuring given the fact that there are also other measurable differences that we've shown earlier. So which means that as a result, we're able to put a number and data based on our opinions of our trainees. Next slide, please. So in conclusion, it's as expected, experienced surgeons do perform better at such benchmarks versus our trainees in efficiency and tissue handling. And it's supported by the subjective perception of a surgical competency by the assessor. So the goal is to develop a standardized assessment tool which can reliably assess the trainee's surgical competency, which is repeatable and can be performed easily. So in terms of future development, we are going to get additional videos, which will be up to 80, assessed by 3 different surgeons, and we'll measure the the inter-observer differences and make sure that it's consistent between the board. And once that is done, then we can develop a marking scheme to mark our trainees and also for them to review themselves. Thank you.
You're most welcome.
Thank you very much. Talk. Christian Makukovic sends in a question. Thinks your talk's great, loves the objectivity of the assessment method. Have you rolled it out or tried it even on an in-house educational basis for any other operation?
No, so at the moment we only done it for lab chole, and of course it's a videoed operation, so it will only work for robotic and laparoscopic surgery as per now, unless we start to use basically like GoPro videos for open surgery. So at the moment it's still in development, and I guess in the US there's a lot of talk about using AIs to analyze videos. But the problem to be able to start that is that in order for the AI to see what is a better operation as per se, it needs to have those parameters tested first. So I guess this is the first step in generating those key points where we need to measure.
Okay, thank you very much. Very interesting. Thank you for joining us, and stay safe in Melbourne.
Thanks.
Krishna?
Okay, so next paper is Improving Patient Experience on Consenting Process for Surgery. Suyan Lee from Manchester, please.
Good evening. My name is Suyan Lee, and I'm a medical student from the University of Manchester. And I would like to thank ASGBI for the opportunity to present. The recent change towards shared decision-making has made considering the patient's views important. Guidelines state that consent should be taken either by the responsible clinician or another suitably trained person well in advance of the procedure. However, patients are often only formally consented with documentation on the day of surgery, raising questions on whether there were enough time for patients to make an informed decision. Our aims of the study were, 1, to evaluate patient satisfaction and preference with the timing of the consent process and consenting clinician for elective treatment, and 2, to review current practice on offering patients their copy of the consent form. Next slide, please. We conducted a prospective study on 115 consecutive adult patients newly admitted for elective surgery from 16th to 23rd May 2019. We used a patient performer shown in the figure on the right to collect data on patient satisfaction on the consent process and patient preferences on consent timing and consenting doctor. Patient preferences and satisfactions were scored using 5-point Likert scale and analyzed using mean and standard deviation. Next slide, please. So for consent timing, we found that most patients were consented on the day of surgery. Patients had a higher satisfaction when they were consented in clinic compared to on the day of surgery. And furthermore, they preferred to be consented in clinic with an addition of an explanation on the day of surgery. Next, the proportion of consents made by different clinician grades was similar, with 44% consented by consultants and 51% by junior doctors. The remaining 5% were unknown. Consultants yielded higher mean patient satisfaction scores across all categories when compared to junior doctors, but most patients did not have a preference for the clinician's grade. And lastly, we found that more than half of the patients did not receive a copy of their consent form, and only 40% received their copy. The other 4% included case notes and consent forms not being found. We also found that similar proportions of patients received their copy regardless of when they have been consented. Next slide, please. So in conclusion, current consent timing does not meet patient preference. Instead, patients should be consented in clinic with further explanation on the day of surgery. The seniority of consenting doctor was not a priority, but consultants had a higher satisfaction rate. We also found that most patients did not receive their consent form, and this goes against the standard of practice. And changes to consent timing and consenting clinicians should be implemented to improve satisfaction rates and the quality of care. Thank you.
Thank you, Shuyan. That's a very good paper. Just wanted to ask you, because a number of patients who we consent, if we were to consent them in the clinic, Then they go on the waiting list, and there's quite a lot of time before they come back to their actual operation. Did you see that? There's a big gap, and then they're pretty much starting fresh once they come on the day of the operation to have their consent.
So I found that the median time from the last appointment date to the time of surgery was around 60 days for the group of patients that I've studied. But the thing was, the patients, even though they had those 2 months of gap between the last appointment date and the surgery date, they did still, a lot more percentage still prefer to have consented in clinic.
Okay, thank you. Ian? Hello, Ian?
Big warning sign on the screen. I'm muted. Rare occurrence. On to Kerry Avery, paper 7, a core outcome set for seamless standardized evaluation and reporting of outcomes through the innovation life cycle. Kerry.
Thank you. So good evening, or very early morning for some of you. As you've just heard, I'll be talking about a study we've undertaken at the Bristol Biomedical Research Centre at the University of Bristol to develop a core outcome set to promote safe and efficient surgical innovation. Next slide, please. So innovation in surgery is really common, and it's central and crucial to improving patient outcomes. For optimal patient care, the outcomes of surgical innovation must be usefully measured, reported, and then shared with the surgical community. But agreement on which outcomes are essential to measure is currently lacking. And this is really problematic because this lack of agreement provides opportunity for selective and potentially biased reporting of outcomes that may exaggerate a procedure's benefits or underestimate its harms. And we've seen evidence of that really recently. And this can result in ineffective or even harmful procedures becoming established in routine practice without a sound evidence base, which poses risks to patient safety. Failure to effectively report and share learning with other surgeons during the process of surgical innovation can also delay the introduction of promising new innovations, again impacting negatively on patient outcomes. As a solution to this problem, the Cohesive study developed a core outcome set, which is an agreed minimum set of outcomes to report in all studies of new surgical procedures and devices to improve the safety and efficiency and the transparency of surgical innovation. Next slide, please. So firstly, we generated a long list of potential outcomes that might be relevant to include in the core outcome set. Now, given the unique context of surgical innovation, multiple different data sources we used to do this, we chose those that had specific relevance to innovation, including, for example, published studies of innovative procedures, case studies, etc., hospital and international regulatory body documents, and interviews with surgeons. And these verbatim outcomes were then categorized into 32 outcome domains. And that was quite a task, because you can see there's 8,000 outcomes there that we categorized into 32 broad domains. And then we had over 400 international key stakeholders rate their importance in an online Delphi survey, including patients, surgeons, methodologists, journal editors, representatives from funding, industry and regulatory bodies as well. And then we held a consensus meeting of around 30 stakeholders to vote and ratify the final core outcome set. Next slide, please. And here is that core outcome set. So there's 8 outcome domains, of which most are specific to the context of early phase evaluation of surgical innovation, while you can see that others are also of relevance and might be measured in later phases of procedures evaluation. So the outcomes include modifications, which includes to the procedure itself, but also the co-interventions or indeed the patients who are offered the procedure completion success, problems with the device working, surgeons' experience, such as, for example, their ergonomic comfort during surgery, patients' experience, disadvantages, specifically including both expected disadvantages and unexpected disadvantages, intended benefits of the procedure, and whether the overall desired effect or aim of the procedure was achieved. So now this is really defining what outcomes of surgical innovation are essential to measure. What we're doing now is undertaking some work to develop a core measurement set to define how these outcomes should be measured. And we're also in the process of developing an electronic platform to allow the real-time reporting and sharing of these outcomes to better promote the safe and transparent surgical innovation. Thank you.
Thank you very much. A topical presentation indeed on the day the Cumberland report came out. Is the problem with new procedures not over-enthusiastic surgeons offering it to over-enthusiastic patients? And will this process not deal with that? Or will this process deal with that?
I think this process will deal with that. It won't deal with it in its entirety by itself, but this is part of a much wider programme of work that we're doing in the BRC to sort of focus on surgical innovation. So there's a whole nother work stream on ethical issues and informed consent. So I'd like to say that I think you're probably right. There is enthusiasm amongst surgeons, quite rightly, given the positivity towards innovation. I don't think all patients are aware that innovation is happening on them particularly. We know of plenty of cases where patients haven't actually been told that they're maybe undergoing a new procedure or that that surgeon hasn't performed it before. And that is something that we're working on alongside this to look at developing policy and recommendations for informed consent. So that's why I particularly found that last presentation interesting.
Yes. Okay. Thank you very much. We'll look forward to that. Krishna, do you want to make a comment?
Yeah, yes, I just wanted to ask Kerry, I know that this is about surgical innovation as such, but do you think it could actually form a sort of a template which could even be used for new devices? Because each time the industry brings in with something new to replace what we've already got an existing one, do you think there's something here which could help do that? Because at the moment there isn't a system. It's very much, you know,
yeah, so this core outcome set is intended for both surgical procedures with or without devices, so it does encompass devices as well. And you're right, there isn't, I think actually the regulation around devices is much more stringent and it's much more evident than it is for surgical procedures that don't involve a device. But yeah, this is there to encompass all of that. And we have worked with the regulatory bodies like the MHRA, etc., to develop this core outcome set. We've had great stakeholder buy-in, so we definitely see that being an outcome.
Thank you.
Okay, we need to move on. Thank you, Kerry. Krishna, do you want to
okay,
do the next
one? Next paper is reduction of hospital admission by means of perioperative patient education. And this from, forgive me for pronunciation, Thai Menzoon Tweet, please. Thank you.
Yes, thank you for the introduction. My name is Thais Menzoon Tweet, and on behalf of my fellow co-authors, and I will present this the reduction of hospital admission by means of perioperative patient education. I will give a short introduction. As many of you know, the ERAS protocol, that is enhanced recovery after surgery. Even after ERAS protocol, we notice a medically unnecessary longer admissions, that they still occur. We were curious to know what the effect would be if we would educate our patients, and part of patient expectation management by introducing expected day of discharge. Next slide, please. Yes, so what we basically did for the patients who were operated in 2016, all those patients, they followed standard ERAS care. We've introduced patient education with expected discharge date in 2017. And we used the intervention group of patients in 2018 to limit the bias. And what the patient education is, it's basically when the patient come into the clinic, we would, based on the resection, we would patients amount of expected hospital days, say for if it's a hemicolectomy, right-sided hemicolectomy, patients would be expected for 3 days. If it's a rectal resection, patients will be expected to stay for 5 days. To reinforce this, a whiteboard was installed in the patient's room, and the EDD, I will further refer to it as EDD, the EDD was always mentioned to the patients before surgery, after surgery, and during admission, both to the patient and to the family, so that they know when they're expected to leave. And the primary outcome of this study was length of stay. Next slide, please. So in total, A total of 587 patients were included, 363 patients followed the standard EROS protocol, and 242 patients followed the intervention, which is the EROS plus. What we see is that the patient in EROS, they had a shorter length of stay with a reduction of about 2 days compared to the patients of the regular EROS group. So those were the patients who followed the standard care without reaching an expected discharge date. Furthermore, fewer patients of EROS Plus experienced severe complications. About 10% in the EROS Plus group, that is about 11% in the EROS, standard EROS care, with a p-value of less than 0.001. No difference was found in the number of reinterventions, admissions, or mortality between the two groups. So that was also a very nice finding for us, as we expected that. Say, if patients were to go home earlier, what are the consequences? Do we see them back, or are they prone to more complications or not? And we found that it did not matter in this case in our study whether the patients went home after 2 or 7 days. Next, please. Yes. So in conclusion, it is possible to reduce length of stay by 2 days within the EROS program, and you can do that very easily by better perioperative education of patients with the use of an EDD without the added risk of readmission or complications. Thank you, that was about it.
Excellent. Thank you very much for that very important talk. Is there time for questions? I think this should be a routine, I would have thought. Ian?
One question come through, two now. Was there a good mix of operations between the groups to compare? Because you wouldn't expect your survival to look different. And was there a surgeon or procedure variation? That's two questions from the same person. Can you answer that for us, Thais?
So as it pertains to the patient characteristics, we saw no difference in the baseline characteristics of all these patients. And these were patients who received colorectal surgery for malignancy. So they were all patients who had cancer. So those were all the same type of resections. We also saw no difference between the two groups and how many patients operated in for a colonic resection or how many patients operated for a rectal resection, because we do know rectal resections tend to be a bit more tricky and patients tend to be a bit more longer admitted for those procedures. And for the second question, was there a surgeon procedure variation? No, we did not see that either.
Yes, what they're getting at is if you have only 30 patients in your series, if you get a big complication, say anastomotic leakage or a pulmonary embolus in one group, when you've only got 30 patients, that might skew your results. Did you see that?
No, we did not find that. And we also did a univariate and a multivariate analysis in order to correct for type of resections, for duration of resection, also for, what was the next one? Oh, and also for the EROS protocol.
Okay. Thank you very much.
Additionally, I think I only have very limited slides, but important to know, we checked to see the reasons why patients did not go home after their set EDD, and about 60% were medically necessary and the remaining were not. So I did find out an important finding as to most people were either uncertain to go home or it was during the weekend. So they would want to wait till Monday to go home.
Okay, well, thank you very much for joining us from the Netherlands. It's a good take-home message to have the EDD written on the board behind the patient's head. Is that right? Okay, thank you very much. We're going to move on to the talking posters now, where there's a slight change of format. There's 3 minutes for each talk, and we'll take all the questions at the end. So please use the Q&A button at the bottom of your Zoom screen, because otherwise we won't remember what the questions are. So I'd like to invite Hafizul Haq to present on VR simulation in a DGH. How's it influenced foundation doctors' confidence?
Hi there, so my name's Hafi, I'm one of the doctors from Southend Hospital and I'm an FY2. So we know from previous research that high fidelity simulation is quite an important aspect of training, both in undergraduate and postgraduate training. We know in things like ALS and ATLS that's highly valued, but there has been very little research done on virtual reality simulation, and by that I mean the headsets that they use, things like Oculus Rift and such. And as part of my project, the East of England Deanery was one of the first deaneries in the F1 FY2 program to introduce virtual reality simulation training into part of the criteria for passing ARCP. So we looked at two sets of cycles of data collection, looking at the FY1 and FY2 doctors who were involved in these training sessions. They were essentially in a room with the headsets. They were given up to 10 cases to complete, and then subsequently I took a group of them, we did a focus group, and then we adjusted the simulation based on the focus group and the questions we asked, and then repeated it with individual interviews. And the main thing we were looking at confidence, and interestingly we found that virtual reality simulation is quite a novel idea for a lot of the doctors. And by novel, I mean it was quite an enjoyable experience. A lot of the times with high fidelity simulation, there's the additional pressure of your colleagues, your peers judging you while you're working. And that can lead to mistakes that you might not necessarily make in clinical practice. And the idea was, can virtual reality simulation mimic a clinical environment enough where you feel like, yeah, I'm engaged with it, and I feel like I'm still, is it like I'm on the wards? And so it was found to be quite immersive. It utilizes the two senses, particularly sight and hearing, and the doctors felt as soon as the headsets were on, they felt like they were completely inside the clinical scenario. It used higher functioning decision making, the decisions that you wouldn't really make, I think, when you're in a high fidelity simulation. Normally you're thinking of A, B, C, D, E, but with the way the cases were organized, you have to think about, okay, how am I going to escalate it? Okay, this patient is unwell, I need to book theatre. Things like decision making skills that you'd use gradually as you progress in your career as a more senior doctor. The juniors had an opportunity to think about that, and that was highly valued. And the feedback provided by the virtual reality simulation was also valued, because you were given a score alongside global feedback with a examiner who was in the room, like an anaesthetist or another senior doctor, to give you feedback. It seemed to be quite a valuable resource, and the next step is kind of getting questionnaire across the whole East of England Deanery to see how preparedness is valued across multiple hospitals. Yeah, very much.
Thank you very much. Krishna, do you want to introduce the next one?
Okay, so next talk is from Wales by Osian James again. Strategic organizational skills predict surgical training success.
Good evening again. My name is Osian. I'm a General Surgery Registrar and a Royal College of Surgeons Research Fellow. I'll be presenting Strategic Organizational Skills Predict Surgical Training Success. So as everyone is aware, progression through surgical training is predominantly dependent on exam success and the desirable outcomes at ARCP. Arguably, there's no other period of training where this is more intense than core surgical training. Many factors have been associated with differential attainment across exams and career achievements, including ethnicity, gender, and academic factors. However, data and organizational skills, particularly in the medical arena, is sparse. The aim of this study was therefore to determine the influence of organizational skills on achievement during the CST. HEIW hold a 3-day induction bootcamp course for core trainees each year. So we looked at the time trainees arrived each day for 3 consecutive years and 125 trainees. This was our composite marker of several organizational skills, including receiving, comprehending, and following instructions, personal administration, and preparation in order to arrive on time. Trainees were told that registration was at 8:45 for a 9 AM start. We then compared their arrival times and whether they were early, on time, or late with our primary outcome measures during the time in CST, which were operative experience, peer-reviewed publication, passing MRCS or DONS, and having a desirable ARCP outcome 1 at CT1 and an outcome 6 at CT2. Median arrival time was 8:53, ranging an hour or so each way. In summary, arrival time was associated with all primary outcome measures on univariable and multivariable analysis. By the end of CT1, early arrivals had 25% more cases in their operative logbook, 206 cases versus 164 cases, were 4 times more likely to have a publication and pass their exams compared to those who were late, with almost 90% achieving a desirable ARCP outcome 1 compared to 60% of the latecomers. By the end of CT2, the exact same patterns emerged, though the gulf between early and late had narrowed slightly, as you can see. If we apply linear modelling to the data, for every minute later trainees arriving in bootcamp, 0.68 fewer cases were performed during the CT1 year. Similarly, trainees who had authored a publication arrived on average 8 minutes earlier than those who hadn't, with similar figures for those passing exams, arriving 6 minutes earlier than those who hadn't passed, and achieving a desirable ARCP outcome, 6 minutes again. All of these demonstrated statistical significance. There was clearly not a causal relationship. We can say with some confidence that the time a trainee arrives at a mandatory training event is an accurate predictor of subsequent performance through training. Pericles said that time is the wisest counselor of all, and from the data presented here, I would be quite inclined to agree. Thank you very much.
Thank you very much. Interesting presentation. On to the next one. We'll take questions at the end, so do send them in, please, on the Q&A button at the bottom of your screen. Number 4 being presented by Amy Gillis from Dublin, multidisciplinary teams and novel program teaching clinical decision making.
Thank you very much for allowing me to present. Our project was my name's Amy Gillis. I'm one of the consultants at Tala University Hospital in Dublin, and essentially our program was developed as a means of trying to formalise critical and clinical decision making for postgraduate trainees. And it was incorporated. We chose to use multidisciplinary team meetings as a medium, essentially, of teaching clinical decision making and the pitfalls and etc. that goes along with that. It was part of a broader course of the Masters in Surgical Science that's offered by the Royal College of Surgeons of Ireland. Essentially our program spanned over the time period of 10 months, and the MDT portion was twice monthly in 2 separate sessions, each 2 hours at a time. The first session of each month was a simulated MDT that was coordinated by a medical oncologist, surgeon, radiologist, pathologist, and then we had guest radiation oncologists as well, depending upon the case. So most often it was cancer cases just because of the nature of MDTs, but we also incorporated non-cancer cases and trauma at different segments. We tried to coordinate our topic with the topics that were progressing throughout the top masters as well. So you'd be surprised, most of our MDTs will have anywhere from 15 to 20 cases per hour, and I thought that with 1 case per session we'd be short, but it actually took almost 2 hours to break down how you make decisions and why each decisions are made in the sessions. And we'd have primers by the radiologist and medical oncologist and the pathologist just for the level of the trainee. The second session was at the alternate weeks was facilitated by a single facilitator, and it was looking at different aspects of clinical decision making, particularly breaking down analytical versus intuitive thought, looking at the role of heuristics and biases, and trying to bring the group through from particularly recognizing their unconscious biases into insight into a more conscious setting. One was particularly the ethical dilemmas that go along with particularly group decision making, as per MDTs usually are. And also, it also carried on from the bias of trying to bring, just by changing the scenario slightly, how their decisions would change just based on their own moral compass. And so that was quite interesting. And then looking also at specific cases of palliative decision making and how that is even the most bespoke of bespoke MDTs. And eventually our evaluation was expected to be simulated MDTs with each of the role play by the students, and they were to be videoed and looked at a 360 plus an external, but unfortunately with COVID we weren't allowed to do any type of interaction, so everything had to move to an online forum. So unfortunately that portion of the evaluation was lost, but hopefully by next year we'll be able to reintroduce that type of aspect. But it was just, this presents sort of a novel means of teaching clinical decision making, which predominantly through training is not a taught phenomenon. It's something that's sort of or absorbed around us, and also just to open up biases that do tend to exist. And the MDT was an excellent forum to display that. So we look forward to progressing this as we go forward in time. So thank you very much.
Okay, thank you very much. An interesting angle. I'm sure we'll want to come back to that in the questions. Krishna?
So thank you. Next is proof of surgical publication prowess, a prospective observational study of factors associated with surrogate markers of academic research. We've got David Robinson back with us from Wales.
Thank you. Good evening again. So I'm going to present our second study, proof of surgical publication prowess. Now, the need for peer-reviewed publications in UK surgical training remains a contentious issue among the surgical community, with some believing it should remain a key part of the curriculum, while others argue a good surgeon is not necessarily a good writer, or that enforcing publication targets leads to poor quality, low value publications. Nonetheless, the requirement remains that to CCT in general surgery, you must obtain 3 significant author publications. Yet we've noted that less trainees are undertaken dedicated out of program research time. So the aim of this study was to see how many trainees among our cohort had achieved the benchmark of 3 publications, and what factors were there that predicted success in this arena. So we examined 59 consecutive higher surgical trainees with the outcome measures, firstly of the number of publications they've achieved to date, and the secondary bibliometric metrics to go with those publications. So the box on the right-hand side shows the comparison between those that undertook a formal period of dedicated out-of-program research and those that didn't, with the highlighted numbers in yellow showing lines of significance. And as you can see, those that undertook formal periods of research had a greater number of total publications, a greater number of first, second, and middle author publications. They were also more likely to have achieved the target of 3 papers, and the number of publications by the end of ST4 and ST6 was significantly higher in those undertaking a period of research. The bibliometrics married up with this, with higher total number of citations, a higher Hirsch index, and higher ResearchGate scores for those who had ResearchGate accounts. We also looked for any gender variation, and what we found using the exact same parameters that we've used for the research aspect was that females were significantly less likely to take dedicated time out of program to do research, however, performed equally to their male counterparts on all fronts, despite not taking this dedicated research time. We also performed a multivariate analysis, looking with the target of being 3 publications. And as we expected, training grade was present. So the more senior the trainee, the more likely it was that they have achieved the target. But also those that took out of program research were 6.5 times more likely to have the 3 publications at the time of the study. So in conclusion, dedicated periods of training dedicated periods out of training for research are advantageous in many ways. But if CCT competencies are to include academic profiles, training programs should incorporate research training within workforce planning to ensure that the opportunities remain to be there for the trainees within their programs. Thank you.
Thank you. Thank you very much, Ian.
Thank you. So keep those questions piling in for the discussion session that follows the final poster, for which we're heading up to the northern wastes of Dundee and Wishaw to Iogu Ugwu, who's telling us about synopsis of our documentation.
Hi, thanks for the introduction. My name is Ajogu Ugu. So the title, Synopsis of Our Documentation, Decision Making and Documentation. Well, as surgeons, we make potential life-changing decisions daily. It's what we do. One of the most important decisions we make is when to operate. It's important that these important discussions are had with patients and their relatives. and it's important that we document accurately in the clinical notes these decisions and discussions in a timely fashion. The Academy of Medical Royal Colleges and the Good Surgical Practice by the Royal College of Surgeons of England give us an idea about, the consent process and what we need to do. However, I'm yet to come across any clear guidelines in the UK that tell us exactly what we should be documenting. And out of this, we decided to, have a look at, our patient record keeping prior to surgery and to propose any areas for improvement if identified. So this was a closed loop audit looking at the clinical notes of all general surgical patients undergoing an emergency surgical procedure. And we excluded patients who were admitted electively. In terms of the parameters we looked at the dates and time the decision was made to operate, the date and time of the actual procedure, whether there was any clear documentation in the notes describing the proposed surgical procedure, and the grade of the medical staff involved. Our findings were presented at the surgical audit and research meeting, and we put our intervention strategies in place, and data was collected prospectively. In terms of the results, we analyzed a total of 36 patient notes, and prior to implementation of our intervention strategies, 33% of the notes had no documentation of the decision being made. Post-implementation of our strategies, 10% had no documentation of decision being made, so that was an improvement. 52 prior to implementation, 52% had no clear documentation of the proposed surgical procedure, and a third of these just documented, quote unquote, for theater. Post-implementation, 21% had no clear documentation of the proposed surgical procedure, with about half of these which just documented, quote unquote, for theater. In conclusion, we demonstrated an improvement with regards to documentation with a definite scope for further improvement. And most surgeons would agree that the bare minimum expected would be a note describing how a provisional diagnosis was arrived at, the discussion with the patient regarding the perceived pathology, and what type of surgical procedure is being proposed. Some of these discussions would usually take place during the consenting process and ad hoc discussions with patients and their families. And in this present medical legal society we are operating in, it's important that we document in these patient notes in a timely fashion. Thank you very much.
Thank you very much. Thank you to all the poster presenters. Just before we go to questions, I just draw your attention to the e-posters which have been submitted to the Centenary meeting. They're available on the website, and there's some great things in there. I had a look through them this afternoon. There's a fascinating range of things, from LTFT to operations to you name it. There's all sorts of little nubbins there that you can go and look at, and that might just stimulate what your session for next year would be. But let's just come back to these posters. Let's stay with Ajogu Ugwu. First of all, if I can just ask you, so you saw quite significant improvements in documentation. Can you maintain that? You're muted. You're muted.
Yes, sorry about that. So yes, there were significant improvements. Going forward, it became evident that after a while, the notes didn't go, the improvement wasn't maintained. But I think this just boils down to reiterating the importance of these, of accurate documentation and clear documentation of decisions and discussions.
Okay. Okay, Krishna, do you have any questions on the thing?
Yeah, so I just wanted to ask Hafiq about the virtual reality simulation, because I don't know if I got that right, there was no control group for that, those group of patients. So you basically, it seemed like it was a good idea to do it, and it definitely is. But what did we compare it with?
So that was one of the limitations of the project. We didn't have a control group. We were looking at previous research. There was a previous set of there was an FY, when I was FY1, there was an FY2 who did a similar style of project, but instead focused purely on high fidelity simulation, but ran it as kind of like a mock-on call series. So I discussed his findings, and looked at previous projects and research really. So that was one limitation of the project.
Thank you.
Could I just ask you, Hafiq, what sort of things, when you have the headset on, do you see? Do you give them a simulated patient or a video or a set of charts or what?
So there are essentially a set of cases. When you put the headset on, you get, if anyone's ever been familiar with playing like video games, essentially it's a very similar kind of style. You put the headset on and immediately you'll have a voiceover telling you, okay, you're a doctor in SAU and your patient is spiking a temperature. Then you have immediately the sick patient in front of you, and you're holding two controllers essentially, and then you then proceed to advance to the patient, and then you have a set of options, numerous options in front of you, and then you essentially work through the case, and then you get a score at the end. That doesn't tell you kind of, during the case whether you've done something right or wrong. You just do the case, and at the end they'll say, okay, you've done this, or you should have escalated it to this level, you should have it was good, you kept the patient nil one mouth, you're suspecting this, and this. So that's the way the case is done. And then obviously you've got the controllers in your hand as well. And something I didn't really talk about, which I think we touched on actually at the very beginning, it's the initial buy-in cost of the headset. Even though it seems quite expensive, these headsets quite, they're £500-600. If you compare that to the mannequins, the quite advanced mannequins we use now for things like ATLS and ALS and such. One advantage is it's not supposed to replace high fidelity simulation. It's more to support it and focus on that higher functioning reasoning skills, as opposed to that the skills, like I said, a senior doctor will be making, as opposed to just A to E. You kind of just go through the motions. So.
Okay, thank you. Maybe a good thing to submit as a video in future years, so that folk could see what it's like inside the headset. I think that's good. Got a question from the floor for Ossian. Great work, and I'm sure we all see this. How would you disseminate this knowledge to trainees to make them realise this, and would that alter the outcome?
Well, the obvious place would be on morning one of next year's boot camp, or this year's boot camp, whichever form it may take, given the what we're going through at the minute. I think the important thing here to note is it's all about engagement. It's everyone's going to be late at some point in their lives to something, but this is on a sort of fairly large population. It's just a matter of engagement. It's not particularly difficult to have logbook cases in your logbook, or getting your WBAs in and things. It's just about organization and engagement. So I think we definitely need to highlight this on morning one at the start of their CT1 year, and we can present hard data now in a currency that they sort of appreciate and understand. Really, they say, look, this is the difference you'll have in cases, blah blah blah, and might be a bit of a switch on moment perhaps, but we'll see.
We'll see. Krishna, do you have any more questions there?
Just one very quick one from David regarding your publication study. So now it's what you basically demonstrated is what you'd expect, that some trainees given time to do research will produce more, will produce their 3 papers that they require. But obviously against that is the time lost on the shop floor, on the clinical side. What is your message through that paper? Are you trying to say that there should be like a middle ground, or do you think maybe the standard about producing the 3 papers is? What are you actually trying to say in that?
It's more about the prompt for it was the fact that we realised that we had some senior registrar trainees in Wales who were not at that sort of set target at a very late stage in their registrar years. And it was more to sort of identify, well, we tell people, you know, here's an opportunity to do a paper during clinical time. And most of us have been there where we've said yes, and then actually it's not come to fruition. And that's not necessarily due to lack of engagement, it's due to you working full time. People, especially during registrar years, have young families and other commitments. And actually it can become quite difficult to hit that target. And before you know it, you're an ST7, ST8, and you've got 0-1 publication, and you need 3 within the next 18 months, which for any of us who have been trying to publish papers through a peer review process, 18 months is not a very long time. So it was more to sort of put a figure on it and demonstrate the power of doing out of program research to meet the current guidelines. But it was also to strike a bit of discussion about whether or not this requirement set for CCT, one, is it necessarily essential? Does it add a great deal for everyone to publish 3 papers? And also, 2, are there other ways that we can sort of do this? But if we're going to stick as we are, we need to demonstrate really that there needs to be adequate funding, there needs to be adequate opportunities for people to be able to take time out. But we are also forcing people to do something they may not necessarily want to do.
Mm-hmm. A dilemma. One final question for Amy then. Teaching MDTs with a panel of expert doctors, it's quite staff heavy, but how much of it is teaching content, so about the cancer in question, and how much of it is teaching analytical or decision-making technique, do you think? How does it pan out in real life?
The second sections are very much all about breaking down decision making. The first ones with the panels are a bit more content. I'd probably say about 50-50. Not so much the actual cancer discussion, because the students are asked to just review in advance about the type of malignancy, if it's that. The more that we focused on radiology pathology, about how other options that they would extend in terms of, just as opposed to just presenting what the pathology is, what are other things that pathologists would want to have done, what other decisions have to be asked about, you know, immunohistochemistry, other types of tests, c-kits, things like that. So we kind of expanded it like that. What we were really trying to do is, it's a small group, so there's only 10 students that were in it, so it was much more easy to have them engage. And after the first session or so, they're very much active participants, and so you're putting on to them, so what would you do in this situation, or what are the questions you need to ask in this situation, and why are you asking them? What do you want to know that's further information? So it kind of evolves as the year built, because they were more accustomed to the next steps, and yes, for those sessions. The others, it was very much all you have a decision, you break it down. It was almost irrelevant what the case nature was, other than the fact that it allowed you to branch into different directions. So, but it's fun.
Interesting. Any other questions from the panelists? No? Okay. In that case, we'll draw the evening to a close. You might like to know there were 50 people watching at one point, which is probably more than we have for a usual short paper question at big meetings. Thank you all for excellent presentations. Thank you for the hard work you've done. I don't follow the education and training literature a great deal, but I've been absolutely fascinated by it. I've really enjoyed it, and it's been a real pleasure to meet you. Thank you for joining, and look forward to seeing you again. And thank you to my co-chair Krishna, and to Vicky and Carol for organising. Thank you and good night.
Thank you very much. Thank you.
Thank you.
Thank you. Good night.